All right, welcome to The Explainer. Today we're unpacking the absolute master of homeostasis, the posterior pituitary gland. This tiny, tiny structure is literally the body's chief architect of water balance. It's constantly making these micro decisions about whether to hold on to fluids or let them go. We're going to dive deep into the precise mechanisms, the fascinating hormones involved, and of course the clinical syndromes that pop up when this highly delicate system gets thrown completely out of balance.
Here is our roadmap for today. We'll kick things off with anatomy and hormones, move right into AVP and the water dam, then tackle diabetes insipidus, the copeptin detective, SIAD, and wrap it all up with a master comparison. Let's get to it.
Section 1, Anatomy and Hormones. So we're starting our anatomical tour by looking at the ideal state of our two key non-anapeptide hormones. These are both produced up in the paraventricular and supraoptic nuclei of the hypothalamus, and then they're stored distally down in the posterior pituitary. Now, what's genuinely wild here is how structurally identical these two hormones are. They're both non-apeptides, meaning they just have 9 amino acids, and get this, they differ by only 2 amino acids at positions 3 and 8. That's it, just 2 amino acids. Yet they have wildly different jobs in the body. AVP is your heavy hitter for antidiuresis. It fiercely retains water. Oxytocin, on the other hand, it has a very minimal antidiuretic effect. Its main gig is triggering milk letdown, stimulating uterine contractions, and working in the central nervous system to drive socio-emotional functions, things like attachment, empathy, and fear extinction. Okay, moving on to Section 2, AVP and the water dam. To really understand AVP, you kind of have to think of it as a highly regulated dam that strictly controls exactly how much water leaves our body. And the absolute most crucial data point for this dam is this number right here, 275 milliosmoles per liter. That is the body's osmotic threshold, or its set point. When your plasma osmolarity creeps above this exact point, which means your blood is getting just a little too concentrated, AVP is released to close the dam and maximize antidiuresis. It's incredibly sensitive too. If osmolality rises just 2 to 4% above this set point, your body is instantly hitting maximum water retention.
So how exactly does it build this dam at the cellular level? Well, AVP binds to V2 receptors on the basal surface of the renal principal cells. This kicks off a GS protein cascade, which spikes intercellular CAMP. That CAMP then basically acts as a signal, telling the cell to insert aquaporin-2 water channels directly into the apical membrane. And just like that, water is rapidly pulled right out of the urine and back into the bloodstream. It's a beautifully efficient system.
But here is a fascinating twist. AVP isn't only triggered by osmolality. You really want to watch out for this because nausea is actually the single most potent non-osmotic stimulus for AVP. If a patient is severely nauseated, their AVP levels can literally skyrocket 50 to 100 times above their normal baseline. Now, on the flip side, and this is a common misconception, pain alone does not directly stimulate AVP unless it's accompanied by a vasovagal response that actually causes nausea or severe drop in blood pressure. All right, Section 3, Diabetes insipidus. So what actually happens when this complex water dam breaks or just wasn't built right in the first place? You end up with massive, uncontrolled water loss. This is a state of polyuria and polydipsia, excessive urination and excessive thirst. And there are 4 distinct ways the system can fail. First, you have central DI, which is a true AVP deficiency stemming right from the pituitary. Second is nephrogenic DI, where the kidneys simply resist the AVP that's there. Third is gestational DI, where placental vasopressinase is actively destroying the AVP during pregnancy. And finally, number 4, primary polydipsia, where a psychiatric condition or certain water health beliefs lead to massive excess fluid intake, which physiologically suppresses AVP entirely. You also absolutely need to keep outside factors in mind. For instance, treating a patient with lithium can directly cause the kidneys to resist AVP. It is the single most common drug cause of nephrogenic diabetes insipidus, so that's a massive clinical pitfall to be aware of. Section 4, the copeptin detective. With all these different types of DI, especially when trying to distinguish between central, nephrogenic, and primary polydipsia, we need a rock-solid way to play clinical detective and find the true culprit. For years and years, clinicians relied on the water deprivation test. But we have a major diagnostic dilemma. That old test is only about 70% accurate overall, and honestly, it's a dismal 41% accurate for identifying primary polydipsia.
So how do we actually diagnose the true cause of polyuria today? Enter the modern hero of endocrinology, copeptin. Measuring AVP directly is notoriously difficult because it degrades so rapidly in the blood. But copeptin, that's the C-terminal segment of the AVP prohormone. It gets released in an exact 1-to-1 ratio with AVP, and crucially, it is highly stable ex vivo. That makes it the absolute perfect diagnostic surrogate. Let's walk through how this builds a near-perfect diagnostic algorithm. Step 1, you check a baseline copeptin level, completely skipping any water deprivation. If it comes back elevated above 21.4 picomoles per liter, boom, you have unequivocally diagnosed AVP resistance, or nephrogenic DI. If it's lower than that, you move to step 2 and infuse hypertonic saline to intentionally drive up the serum sodium. Now, step 3. If the sodium hits 150 but the copeptin stays below 4.9, you have AVP deficiency. This elegant test separates deficiency from polydipsia with an incredible 96.5% accuracy. Fixing the dam, treatment options. Let's get into it. Once we've nailed down the diagnosis, we've got to fix that dam. For central DI, our go-to is DDAVP, also known as desmopressin. An incredibly easy way to remember how this works is the mnemonic V2 selector. DDAVP is V2 selective, meaning it exclusively acts on the kidneys, totally ignoring the blood vessels. It has a significantly longer half-life than natural AVP. It is fully resistant to degradation by vasopressinase, which is why it's a lifesaver for gestational DI. And finally, it can be administered via varying routes, IV, subcutaneous, nasal, or oral. Just keep in mind its most common complication is dilutional hyponatremia. Moving on to Section 5, SIAD, too much water. Let's completely tip the scales in the opposite direction now. Welcome to the syndrome of inappropriate antidiuresis, or SIDE, where the dam stubbornly refuses to open, even when the body is essentially drowning in water. The hallmark here is this really vivid clinical contrast, euvolemic hyponatremia. Despite having severely diluted hypotonic plasma, the patient is totally euvolemic. That means they have no edema and no severe dehydration. Yet, their kidneys are inappropriately concentrating their urine to well above 100 to 200 milliosmoles per liter. On top of that, they are continuously bleeding sodium into their urine, typically at a rate greater than 30 millimoles per liter. But hold on, there is a vital catch here. SIAD is fundamentally a diagnosis of exclusion. Glucocorticoid deficiency can present with a clinical picture that is virtually identical. You absolutely must exclude secondary adrenal insufficiency and check thyroid function before you can confidently stamp a patient with the diagnosis of SIAD. So how do we force this stubborn dam open? Well, first-line therapy for chronic SIAD is just simple fluid restriction. But beware, this is very often completely ineffective if the urine osmolality is over 500. Second-line treatments include urea, which literally forces an osmotic diuresis, or tolvaptan. Tolvaptan is brilliant because it's a direct V2 receptor antagonist. It stops AVP right at the receptor level, actively preventing it from building the dam and forcing pure water diuresis. For the severe neurologically symptomatic cases, though, we have to carefully turn to 3% hypertonic saline.
Finally, Section 6, the master comparison.
To really solidify everything we've covered today, let's look at all these conditions side by side. The dichotomies of water balance here are just brilliant to look at. Take serum sodium, for example. Diabetes insipidus presents with high or high normal sodium because the body is dumping free water. SIAD, however, presents with dangerously low sodium because the body is hoarding free water. Meanwhile, primary polydipsia typically presents with low normal sodium. And just notice how copeptin perfectly slices through all the confusion. It's low in central DI, incredibly high in nephrogenic DI, and inappropriately elevated in SIAD. It all just clicks into place.
Real quick, before we finish up, there is one fascinating, albeit rare, condition I have to mention. Adipsic hypernatremia. Normally, your thirst mechanism kicks in at an osmolality about 3% higher than your AVP set point. But in this specific condition, the osmoreceptors regulating thirst are completely destroyed, often by an anterior communicating artery aneurysm. The thirst mechanism literally fails entirely. This forces a state of chronic severe dehydration because the patient simply has zero desire to drink water, even when they are dangerously hypernatremic. I'm going to leave you with one final provocative question. Say you have a patient with severe SIAD and profound hyponatremia. If you rush in with hypertonic saline to correct their sodium too quickly, what deadly consequence occurs? The answer is osmotic demyelination syndrome.
It is a stark, very real reminder that when you're dealing with a body's delicate master balance of water, acting too aggressively, trying to fix things too fast, can actually be just as deadly as the disease itself. Keep that balance in mind, and thank you so much for joining me on this explainer.